right, let's dig into the first of our cardiovascular unit, and let's talk about some anti-anginal drugs. One condition we're going to run into quite often is angina pectoris, or just angina, or depending on how southern you are, it might be angina, right? So, angina is just chest discomfort, chest pain, but caused by cardiac ischemia. So we've got cardiac cells who need oxygen. They need oxygen. They're demanding oxygen, but the supply coming to them for whatever reason is just not enough. This is going to turn into a chronic condition, but your typical chest pain is a sign of ischemia, cardiac ischemia. We're just going to call that angina. If we let that ischemia continue to develop and we don't treat it and we don't, we just ignore it, well, it's going to become this myocardial infarction. This is your MI. This is your heart attack. This is your STEMI, or might show up on your EKG as a STEMI, an ST elevation MI. But the myocardial infarction is your heart attack. Your angina, your chest pain that comes and goes, every now and then. When I'm mowing the lawn, it's chronic. It just happens all the time. Your MI, this heart attack, that's an acute condition. You're not having heart attacks all the time, all day long. So it's an acute condition, you have a heart attack, and this is when a coronary artery, wherever along the branches of our coronary arteries, becomes blocked. And so we have this clot in our coronary artery. And these clots typically form from this plaque, and we've got a normal artery there up on the top, and then this kind of um, narrowed artery on the bottom. So we've got this plaque forming and kind of building up and building up and building up over time, and that's going to create just a smaller area, smaller like kind of lumen, right? That area where the blood flows, the inside of the arteries are lumen. It's going to cut down on that lumen. There's much less blood flow. So when I say that the cardiac cells have all this oxygen demand, they're not getting it. Well, this is one of the reasons. Supply has been diminished because blood flow through that artery has been diminished. And if we look at just a cross section of this guy's coronary artery, I think you can guess how this patient fared if we're taking a cross section and putting it on a slide post mortem. But this is one of his coronary arteries. You can see the artery wall all the way around the outside, and then the lumen, this white area, this is the open space for blood to flow, and the rest of this is this plaque. So all this plaque is just cut down. This should all be open blood flow, but now it's not. So that part of its heart was not getting the oxygen that it needed. All this takes us back to supply and demand. Your cardiac cells, your myocardial cells, they need oxygen. They demand oxygen, and your coronary arteries supply that oxygen through blood flow. So we've got this supply that's determined by blood flow, decreased by all this plaque that narrows the lumen of our arteries. So we can decrease supply that way. And then demand, so we can play with demand a little bit as well. So if we are working out a little bit more, if we are increasing the workload on the heart, the heart's going to demand more. These cardiac cells are going to demand more. Just like if we were to go and exercise, if I were to go out and run, 2 miles, my heart's going to be demanding more oxygen, even though the supply is fine. Demand goes up, and so when supply does not meet demand, that's when we run into issues. And these issues will first manifest themselves as angina, and we've got typical angina, we've got atypical. So let's talk about typical first. Typical angina, we've got stable and unstable angina. Well, what's the difference between the two? Stable angina, usually exercise induced. So I'm increasing my demand, and supply can't keep up with that demand. When I rest, that chest pain goes away. So I get chest pain when I go out and run 2 miles. When I stop running and sit down, my chest pain goes away and I feel fine. That is stable angina. Unstable angina will just happen any old time. I'm sitting on the couch, I'm watching TV, and all of a sudden I get chest pain. If I get chest pain without um, without any exercise, without an increase in demand. That's kind of a precursor to this myocardial infarction. So unstable angina, much worse than stable angina. Stable angina, we're just going to monitor. Maybe your patient might be on a couple medications just in case. Unstable angina, that's typically when we get called out. It's typically when people call 911 because, hey, I was just sitting there and all of a sudden I got this really bad chest pain. I felt terrible and it just has not gone away. And then atypical angina or variant angina or Prince-Metal's angina is still chest pain, but it's not occurring because of any blockages in the heart. It's not occurring because of any of that plaque buildup. It's not occurring because of any of that. It's a result of coronary vasospasm. So you've got vasospasm, you've got these little arterial spasms in your heart, and that is what is blocking off supply. So we've got a little bit of coronary artery spasm that closes off a little bit of the coronary artery and cuts down on blood supply to part of the heart. Typically with these patients, no underlying disease, no medical history, no cardiac history, and if we give them some of our first line, front line medications, they feel much better. And these patients typically have never had this before, no history, and it's just a little coronary spasm. Still should be checked out and treated as such, as chest pain, but no underlying major cardiac disease.